Welcome to another episode of the MEGIN Spotlight series. Today, we're delighted to welcome Dr. Debopam Samanta, Professor in Pediatric Neurology and Medical Director of the MEG Lab, and Dr. Diana Escalona Vargas, Assistant Professor and Scientific Director of the MEG Lab at Arkansas Children's Hospital. As part of the nationally recognized neurology and neurosurgery departments, they contribute to leading-edge research and advanced treatments in pediatric epilepsy and neurological care. Arkansas Children's is ranked among the nation's best by U.S. News & World Report and is home to a Level 4 epilepsy center, offering the highest standard of care for children with neurological conditions. Hello, Dr. Samanta and Dr. Escalona Vargas. Welcome to the Spotlight.
Hello.
Hello, thank you very much for having us to talk about our MEG clinical program and research program.
Thank you, and we're so happy to have you both on the Spotlight today. So let's start with our first question. MEG is currently used clinically in the pediatric epilepsy and brain tumor programs at Arkansas Children's. Dr. Samanta, can you tell us what makes a good candidate for receiving a MEG scan for epilepsy treatment?
Thank you for that question. MEG plays a really crucial part in patients with drug-resistant epilepsy. That means patients who are continuing to have seizures despite 2 or more anti-seizure medications would be good candidate for pre-surgical evaluation, and MEG plays a really important part in that. MEG particularly helpful when MRI scan does not provide a clear lesion. We call these patients had non-lesional epilepsy. Sometimes MRI would show multiple lesions in the brain MRI, but would not provide useful data about which lesion we can go after in the epilepsy surgical process. And sometimes MRI would show a really large lesion, but we need to have more highly precise epileptogenic zone information. Besides this, there are a few different types of epilepsy where MEG could be most valuable. For example, if we have a patient with insular epilepsy or epilepsy coming from intrasylvian cortex or intrahemispheric epilepsy, for example, seizure coming from either mesial frontal region or mesial occipital region. In these cases, we see MEG provides very, very useful information. And what we have seen over the years, we used to see cases where MRI and clinical information and sometimes video EEG would be enough to move forward with epilepsy surgery. But in recent time, we are seeing more complex cases where there is significant discrepancy between clinical data, EEG, and MRI, and we need more ancillary information such as MEG to provide us useful data to move forward with epilepsy surgery. So in summary, we want to provide most comprehensive data to the patient and family so that we can adequately do pre-surgical evaluation, and MEG plays an important role in that regard.
Thank you. So how does MEG inform clinical decision-making when placing neuromodulation devices such as DBS?
Yes, that's a very important question because we are seeing huge explosion in terms of use of neuromodulation. As you know, there are different types of neuromodulation devices like VNS, which is vagal nerve stimulation, DBS, which is deep brain stimulation, and RNS, or responsive neural stimulation. And many times when we are thinking about neuromodulation, that means that we think that these patients are not good candidates for resection or ablation surgery. So in a way, neuromodulation is these are palliative procedures. And we think that these patients are not good candidates for resection or ablation because many times they have very diffuse or widespread, generalized, bilateral epileptic distribution, epileptiform activities. And sometimes, very surprisingly, when we do MEG for these patients, many of these patients actually have more focal, very precise epileptogenic zone that can be targeted with epilepsy surgery. So we routinely do all these patients fast MEG because that actually can change our treatment plan from going from neuromodulation to either resection or ablation surgery. Secondly, some of the neuromodulation device, for example, RNS, you still need to have highly precise data in terms of epileptogenic zone so that you can leverage that information to put electrode inside the brain. So though it's a neuromodulation or palliative procedure, you still need to have highly precise data that MEG can definitely provide.
So can you tell us more about MEG utilization in the brain tumor treatment program at Arkansas Children's? Why are the findings and data provided to neurologists so essential when dealing with brain tumor patients?
Yes, MEG definitely helpful for brain tumor patients because it can provide highly precise functional data. So to identify critical eloquent cortex that's responsible for sensation, movement, vision, or speech. And neurosurgeons routinely use these to map to decide about which area they can safely do surgery to maximize the tumor removal without compromise functional outcome. And we routinely use this as complementary process to other non-invasive mapping process such as functional MRI and diffuse tensor imaging. One beautiful part of MEG that many of these functional mapping can be done passively. That means that the participants, don't need to actively do some sort of task to identify these areas. For example, sensation and language. We have really robust paradigm in terms of passive mapping of these areas. And neurosurgeons really like this type of data gathered preoperatively because many pediatric patients, they cannot cooperate during the surgery in terms of intraoperative wake monitoring. So having this type of MEG data preoperatively, very, very helpful for neurosurgeons to do safe and effective surgery. The other part, which is also very important, is tumor-related epilepsy. We see many patients who continue to have seizure despite their tumor removal. And we want to identify area which would be adjacent to the tumor that's responsible for epilepsy. And MEG actually is very helpful. Sometimes we have a very large cavity after the surgery of tumor, and we want to know where is the residual tumor tissue or scar tissue that's causing continuing seizures. And MEG is really helpful to pinpoint those areas.
So expanding on this a bit further, are you able to share an example where MEG has made a difference in the treatment planning and clinical decision-making of a brain tumor case?
Yeah, there are so many examples that I can talk about. One specifically, I am thinking that we have done soon after we established our program in 2019 or early 2020. So she was a teenager. I think she presented to us around 12 or 13 years of age, but she had seizures since age 5. And she had underwent extensive workup, including multiple EEGs, brain MRI, PET scan, and other ancillary diagnostic studies. But she was thought to be not a candidate for epilepsy surgery because her MRI was non-lesional. And when she had her EEG interictally in between her seizures, she did not have any epileptiform discharges. And during her seizure, there was no lateralizing or localizing feature that surgeon and the epilepsy team would feel confident about going for surgery. And most of her seizures were in the middle of night, out of sleep, and she would have convulsive seizure. Now, only few seizures she had during wake state. She mentioned she had some sort of abnormal sensation inside her mouth. She would have some tingling sensation. But several years, we could not do anything for her. And we continued to manage with anti-seizure medications because we did not think she would be a great candidate for surgery. And then we had our MEG program, and she was one of our first patients that underwent MEG. And we noticed a very tight clusters of epileptogenic dipoles over left side of her Rolandic area, which control her face. That made perfect sense that why she would have that sensation inside her mouth before her seizure. And based on that, only that information, we underwent for stereo EEG. And even when in the operating room, when surgeon put the electrode in that area, there was near continuous pipe wave discharges. So based on that information, she underwent a very small resection and became completely seizure-free. It was a focal cortical dysplasia type 1, which we routinely see that the MRI can be negative or non-lesional. But this is not kind of an isolated case. I would say the cases we do, maybe 1/3 to half of the cases we receive some sort of non-redundant information from MEG that significantly change the future diagnostic and treatment process.
That was a really interesting case to share. Thank you so much. So the University of Arkansas for Medical Science, UAMS, hosts the first of its kind fetal MEG device called SARA. Dr. Escalona Vargas, could you tell us about your work with fetal MEG?
Yeah, thank you very much for that question. So the SARA system, which stands for Squid Array for Reproductive Assessment, is the world's first MEG sensing system designed specifically for fetal assessments. And actually, the SARA system is located very close to Arkansas Children's Hospital. So it's about probably 5 minutes driving between the two campuses. So the SARA was developed through an NIH grant, and it has been operational at the university at UMS for over 20 years, continuously supported by federal funded grants. Under the leadership of Dr. Harry Warren, I've been part of the SARA team for more than 10 years, since 2013. So the system is designed to cover the entire maternal abdomen using 150 MEG sensors. And basically our main focus on is research. Particularly, we are studying fetal electrophysiology, including fetal heart and fetal brain, as well as maternal physiology. Since we are covering the whole abdomen, we can as well study the maternal physiology, such as pelvic floor and uterine activity. One of the key clinical applications of the SARA system is fetal heart assessments. So we have a very close collaboration with our pediatric cardiologists here at Arkansas Children's Hospital and the gynecologist at the university to extract fetal magnetocardiograms or fetal MCG. This is a MEG-based technique that we all know that offers superior temporal resolution in capturing fetal cardiac activity compared to traditional methods. So basically, our fetal cardiac studies provide a very valuable complementary information that enhance the pediatric cardiologist's ultrasound findings. So this information contribute to a more comprehensive understanding of the fetal heart function, and as well we can obtain, or we can use, calculate basically the fetal heart rate variability to assess indirect fetal neurodevelopment. So in future, we aim to expand our research by integrating the information of both the fetal MEG system at the university and our whole head MEG system and Arkansas Children's. So our idea is that we can use both systems to record brain activity and track and quantify the brain activity from the fetal stage through childhood. That is a very unique opportunity that we have here in Arkansas, that we have two MEG systems where we can use it to study neurodevelopment. So stay tuned for our upcoming research, where we are going to use both MEG systems.
Yes, we'll certainly stay tuned. So Arkansas Children's is one of the few pediatric hospitals in the region with the ROSA One brain on site. How is MEG used in conjunction with ROSA?
Yes, we are fortunate to have both MEG and ROSA here in Arkansas Children. And as we discussed today, that MEG is so helpful to provide precise data that can be abnormal brain activity as well as normal functional brain activity. And we can use those data to our neuronavigation system. And surgeon can leverage ROSA to have those information applied using the ROSA robot to put electrodes in very precise areas to make sure that it's actually covering the abnormal area that we want to know if the seizures are coming from those areas, but also make sure it's not compromising critically important areas in the brain. So in general, like combination of MEG and ROSA provides us very efficient and safe way that we can approach epilepsy surgery as well as other neurosurgical procedures.
And from a hospital administration perspective, how has Arkansas Children's Hospital achieved their ROI from having MEG technology as a standard in the epilepsy and brain tumor programs? Have you seen an increase in the number of scans since you've installed? How do you generate referrals from in-state and out-of-state patients?
Yes, we actually have a huge return of investment since we started the program 5 years ago. Since then, we have completed almost 300 plus, almost 300 MEG. And year after year, we're seeing increase the number of evaluation we are doing. Definitely, we have a lot more referral from inside our system from Arkansas children, but we are also seeing large increase in referral from our partner from University of Arkansas and Medical Sciences. So right now, we are almost quarter of our patients coming from outside of the Arkansas Children's Hospital. And this is based on definitely improved patient outcome because we can provide such precise and high quality MEG data that's immediately helpful for patient management. But also we are actively participating with our referring center like UAMS during our epilepsy conference. So there we are not only sending the report for complex cases, actually we are discussing raw MEG data, how we are coming up with these dipoles. So that actually progressively increased in terms of trust and confidence in our ability to provide high quality data. So that increase significantly has increased our referral pool of patients. And lastly, in terms of return of investment is the huge increase in terms of our national prominence and reputation as our ability to provide cutting edge clinical and research quality MEG data for our patients. So that actually reinforced Arkansas Children's reputation as one of the regional and national leader in pediatric neuroscience.
And finally, Dr. Escalona Vargas, since installing the Tri-X Neo, can you please share your experience with the internal helium recycler? Has this helped to improve operational costs and efficiency?
Yes, definitely. So the internal helium recycle has been amazing for our Arkansas Children's MEG system, and is one of the best features that I can say that MEGIN has introduced. We have had no issues with its operation, and it runs very, very smoothly, allowing us to conduct both clinical and research studies on the same day without performance concerns. Even for prolonged clinical MEG studies under sedation, because we are a pediatric hospital and we as well conduct MEG studies under sedation for some of the kids. So the system really remains very stable, delivering high quality data without the disruptions. Additionally, the recycle has well significantly reduced the operating cost by minimizing the helium consumption. I will say that compared to the fetal MEG, it's a system that we still need to fill the system every week with helium. So in here we see really a reduction of the operating cost that we don't need to purchase any helium at all, only once a year and only for the preventive maintenance. So it's been amazing.
So thank you both for joining us today. It's been a pleasure to hear about your work at Arkansas Children's Hospital and more about the program. So thank you again. I think this will be a great episode for our audience as well.
Thank you for having us.
Thank you for having us.
Thank you.